Hello students, good evening. Good evening. Welcome to the RDX series conducted by DocTutorials, where we are discussing the rank decider series for your upcoming exams, mainly INI as well as NEET PG exams. So in this session, I would be covering 20 high-yield topics from OBS and Guide. I know now you're all very much busy with your preparation. So this is going to be a crisp discussion on these 20 questions. If at all you have any queries or doubts in between, feel free to ask in the comment section as well. So I hope all of you have given this test as well. It's very important that you give this test, which are conducted free as well, so that you have an assessment of how you're preparing as well. Along with that, you get the knack of solving MCQs as well. It's not just enough just going through your theory or whatever notes you have. At the same time, it's very essential that you practice questions as well. Because many times it so happens that sometimes you don't know the exact answer, but many times you are able to come to the answer by ruling out the options as well. I hope you are all preparing well for your exams. Yes. Yes. Good evening. Good evening to everyone. Yes. So let's go into the questions one by one. So this is the first question. A patient who's on OC pills has presented with vaginal discharge, and you note that there is no itching or foul smell as such. On examination, there is a slight yellowish color, and along with that, there is normal lactobacilli and pH was acidic. What's the most probable diagnosis? This is a very favorite question again from the chapter of genital infection. Among the lower genital infections leading to vaginitis, there are three important causes, including candidiasis, bacterial vaginosis, and trichomonas infection. So let's have a look at this question from the points. Question is giving you pH is acidic. Among these three infections, it is candidiasis that happens in an acidic pH. But along with that, you know that there is no itching. And again, you know that pruritus is a very important symptom that you associate along with your candidiasis. What else could be this? So every discharge that happens in a woman is not pathological. Many times there is this normal vaginal discharge that happens, which is under influence of estrogen, which is known as your physiological discharge. So this is an example of physiological discharge. In physiological discharge, it is typically under influence of your estrogen, and it is usually just before the day of ovulation, on those days prior to day of ovulation. So question will give you, she has profuse discharge on 12th day, 13th day. Around that day, you have the maximum discharge that you see, and associated with that, there is no abnormalities as such as no foul smell, no itching is associated. Again, the lactobacilli, which is normally present in the vagina, is present in this as well. In lactobacilli, it is the dordaline bacilli that converts your glycogen into lactic acid, maintaining the vaginal pH acidic. So let's have a look at the other three infections as well. Again, this question which I have framed here, this has come multiple times for your previous questions as well. It's very important that you are aware of this condition, that's normal vaginal discharge. Let's go into the others as well. So as we discussed, these are the other three vaginitis causing infections. You have bacterial vaginosis, trichomonas, candidiasis. White discharge, which is typically known as the cottage cheese type of discharge, is associated with your candidiasis. In trichomonas, you get a characteristic green frothy discharge, whereas bacterial vaginosis, there is a thin gray white discharge, and it is usually profuse. In candida, you get a more of thick curdy type of discharge, whereas bacterial vaginosis is profuse, thin gray white discharge. Among these, the pH of vagina is maintained as the acidic pH, which is 3.5 to 4.5, only in candidiasis. In the other two, you see that the pH shifts towards more alkaline side. It becomes more than 4.5. Itching is absent in bacterial vaginosis, whereas they are present in candidiasis as well as trichomonas. Let's look at few of the characteristic features that you see. Candidiasis, patient usually has this itching, and many times they can have excoriation in the vagina or over the vulva as well. So when they pass urine, they can feel that there is a burning sensation, which is basically due to the splashing of this urine over the excoriation, known as splash dysuria. So question can even give you dysuria. Dysuria is not just think about UTI, again think about your candidiasis as well. Yes, thick curdy white discharge along with splash dysuria, think about candidiasis. Trichomonas, you have strawberry vagina and strawberry cervix. You see this red dots over the cervix as well as vagina, which gives the appearance of strawberry vagina and strawberry cervix. In case of your bacterial vaginosis, there is fishy odor seen. There can be presence of clue cells. Clue cells. What are clue cells? Again, an important question. Clue cells are basically vaginal epithelial cells that are studded with bacteria. So you can see the vaginal epithelial cells which are completely studded with this bacteria, that is your clue cells. Again, the criteria that you see along with your bacterial vaginosis is Amsel's criteria. Where do you use Amsel's criteria? Where do you use new gen scoring? All these are associated with your bacterial vaginosis. The investigation of choice is wet mount microscopy. Coming to the treatment. For candidiasis, as it is a fungal infection, we treat it with azoles, particularly fluconazole. Whereas for bacterial vaginosis, as well as your trichomonas infection, we give metronidazole. Where do you give partner treatment? Partner treatment is only given in case of your trichomonas infection. So partner treatment is required. Again, that's an important question. As your bacterial vaginosis is not a sexually transmitted infection, there is no requirement of partner treatment. Again, this seems like a simple box, but there have been so many questions on this. Again, in NEET, they like to ask about the normal things as well, to make you to assess whether you are understanding what is normal and abnormal. Twice this question had come on the normal physiological discharge as well. Yes. Moving ahead with the next question. Is it clear? Yes. Good evening, dear. Good evening. Yes. What is whiff test? Again, whiff test again comes under bacterial vaginosis itself. In Amsel's criteria, there are 4 things that you actually see. In your Amsel's criteria, you see that the pH is more than 4.5. There is presence of clue cells as well. And clue cells, what are they? They are basically vaginal epithelial cells that are studded with the bacteria. There is thin gray white homogeneous discharge that you see, and whiff test is positive. What is whiff test? When you add KOH to the discharge, there is a typical ammoniacal smell. Any 3 among these 4 is positive, you diagnose it as bacterial vaginosis. That's your Amsel's criteria. Yes, let's move ahead to the next question. You have a 24-year-old female who has presented with complaints of dysmenorrhea, deep pelvic pain, and infertility. Examination reveals that there is a tender adnexal mass with fixed retroverted uterus. Again, it's very typical of which condition? This is very typical of your endometriosis. In endometriosis, the most common symptom that you see, the most common symptom as such is pain. Among pain which is seen, it is dysmenorrhea. So when you see a question with pain as the main thing, dysmenorrhea, think about your endometriosis. After pain comes infertility and adnexal mass. Adnexal mass is basically due to your endometrioma. This is due to endometrioma, which is also known as endometriotic cyst, which is also known as chocolate cyst. Why? There is chocolate colored fluid that leaks out if you puncture this. Yes, what is the best investigation in the initial diagnosis of this condition? What is it? The best investigation in this is laparoscopy. So let's see what all variation can come from this question. If they ask you what is the next investigation or the initial investigation that you're going to do, the initial investigation is actually ultrasound. Which ultrasound? It is TVS. You won't directly go to laparoscopy directly for a patient who comes in your OPD. You're first going to evaluate it with your ultrasound. What will ultrasound tell you? Ultrasound helps you to rule out other causes of dysmenorrhea. Apart from this, If there is an endometrioma, again you can see it in ultrasound. How will the endometrioma appear in ultrasound? The endometriosis or endometriotic cyst or endometrioma has a ground glass appearance. It has ground glass appearance. Again, a very important question. Ground glass appearance is associated with endometrioma or endometriotic cyst or chocolate cyst. What is the investigation of choice or best investigation? That is your laparoscopy. What is the gold standard investigation? Gold standard investigation or the investigation for a definitive diagnosis, it is laparoscopy plus histopathological examination. So what is the confirmatory diagnosis? If at all you see that there is presence of this endometriotic glands and stroma outside the uterus, that is when you can say for confirmatory that this is a case of endometriosis. When will you come to that diagnosis? With laparoscopy and histopathology. Suppose your examiner does not give you both options. That often happens now. They will give you both these things separately. One is laparoscopy, one is histopathology. Which one will you choose? The confirmatory diagnosis is basically by seeing this endometriotic glands and stroma outside the uterus by histopathological examination. So for confirmatory investigation, if you have to choose one, it is histopathology. If that's not given in the option, next thing is laparoscopy. So best is the gold standard is lapro and histopathology. If you have to choose separately, this is how you choose. The investigation of choice or the best investigation is laparoscopy. Gold standard or definitive diagnosis is laparoscopy, histopathological examination. Small topic, but very important. So many questions come from this as well. So what all do you see in laparoscopy as such? In laparoscopy, you can see features like burnt powder appearance, or you can see red flame lesions. Gunshot appearance is another term for this black dot-like lesions that you see. So these lesions can be seen. You can see the red flame lesions. All these are the things that you can see in laparoscopic examination. So again, these examination findings, when you palpate, are again important. Tender, fixed, retroverted uterus. Why? The most common site that is associated with endometriosis is your ovary. Most common site is actually ovary. Next comes your pouch of Douglas. So when there is this adhesions, when there is this deposits that's involving pouch of Douglas, uterosacrals, all these areas, there can be adhesions that form, and these adhesions can pull the uterus back, giving you a retroverted uterus. What is the normal position of uterus? It's something like this. It is anteverted and anteflexed, whereas in this condition, you get a retroverted uterus. You get a fixed retroverted uterus. There can be nodules in the pouch of Douglas, as we discussed, which gives you nodularity and tenderness in the pouch of Douglas. Apart from this pain of dysmenorrhea, what other types of pain could be associated? Patient can have dyspareunia, pain during intercourse. The patient can have a chronic pelvic pain. So basically, question will give you pain, pain, pain. So if you see such a question which typically has pain with other characteristic features, think about your endometriosis. Yes. So let's look into the next question. You have a 12-year-old young girl who has presented with acute pain in lower abdomen. She complains of cyclical pain. Cyclical pain is there for the past 5 months. She has not attained menarche yet. On per-rectal examination, a bulge is felt along the entire length of vagina. What is the most probable cause? What are the main clues that is there? Patient has not attained menarche yet, but still I'm not concerned. Should I be concerned in this scenario? Actually, we have to be concerned because of these findings that she is having, or else if patient had just come with complaints of not attained menstruation till date and she is just 12 years, that's not when we evaluate. It's actually 13 and 15 years. 13 years if there is no secondary sexual characters, 15 years if there is presence of secondary sexual characters. That 16 and 14 are the older one, guys. Current Novak is actually mentioning 13 and 15, which has been previously tested for the INICET exam as well. So if there is no secondary sexual characters by 13 years, and if there is presence of secondary sexual characters by 15 years, also the girl does not have menarche, then we will call it as primary amenorrhea. But in this question, it is important. The question is giving you cyclical abdominal pain, which is along with that, there is a swelling along the entire length of vagina. What are the possibilities why this can happen? So suppose this is your vagina and there is a condition known as imperforate hymen. So the hymen has not perforated, or this could be associated with a transverse vaginal septum. What will happen? The blood will accumulate within the vagina, within the uterus, leading to hematocolpos, that is blood in the vagina, or hematometra, that is blood in the uterus. How to differentiate between this? On examination, a very typical sign that is seen is bulging bluish membrane. Let me show you that as well. This is your bulging bluish membrane that is typical of your imperforate hymen. Again, as the uterus is filled with blood, both these conditions can have a per-abdominal mass. This mass can press over your bladder, leading to urinary retention as well. She is menstruating, but the blood is not coming outside in both these conditions. Hence, it is known as cryptomenorrhea. This is known as cryptomenorrhea or hidden menstruation, right? Cryptomenorrhea or hidden menstruation. Key features that will help you to differentiate both these conditions: your bulging bluish membrane that increases in size on valsalva, on cuffing, on straining, that is your imperforate hymen. Whereas transverse vaginal septum, this septa is slightly higher up. So when you look from below, as this is septa is obstructing your view, you cannot see the cervix. When you look from below, you will see a very short vagina as well. Yes. And also the blood is accumulating over the upper part of your vagina, above the transverse vaginal septum. So here, imperforate hymen, the hymen is much lower. If I draw it diagrammatically, it is somewhere here. So in this condition, you can see blood along the entire length of vagina. Here in this question, we have not confused you further by giving both these options of transverse vaginal septum and imperforate hymen. If at all that was given, in the same question also, you will answer it as imperforate hymen because there is swelling along the entire length of vagina, again pointing more towards imperforate hymen. Again, among these two conditions, which is more common, it is imperforate hymen. What is the management of imperforate hymen? You are going to give a cruciate incision. The management is cruciate incision. Cruciate incision. Whereas transverse vaginal septum, you are going to excise the septum. You will go for septal excision. Excision of septum. Excision of the septum is done. What about the other conditions? So this was about your imperforate hymen. What about the other conditions such as Mayer-Rokitansky-Kuster-Hauser syndrome? So MRKH is basically a condition associated with Mullerian agenesis. There is Mullerian agenesis. So anything related to the development of Mullerian duct, all those things are absent. What all structures are formed from the Mullerian duct? The fused part of the Mullerian duct leads to the development of upper vagina, the uterus. The unfused part forms the fallopian tube. So all these structures are absent. These are basically karyotypically, they are females. It is 46XX itself. So ovary is present. The hormones are normal. The lower part of vagina is present. Ovary is present. The lower vagina is present. What is absent? In this condition of MRKH, you see that uterus is absent. The cervix is absent. Again, upper vagina is absent. Upper vagina is absent. Again, this condition will not present with your cyclical abdominal pain. Cyclical abdominal pain is basically due to the collection of blood in every cycle within the uterus and vagina. Here, uterus itself is absent. Again, that's not pointing towards this. Next option, that is testicular feminization syndrome, also known as androgen insensitivity syndrome. In AIS, basically, it is a condition which is 46XY. 46XY. But as the name suggests, androgen insensitivity syndrome, the body is not sensitive to the androgen, due to which the testosterone, the dihydrotestosterone is not acting well, due to which the internal structures, that is the Wolffian duct, is not developing. The external genitalia, actually the development of the male external genitalia requires dihydrotestosterone to act, which is the potent form of testosterone. Again, there is androgen insensitivity, so external genitalia becomes that of a female external genitalia. They have gonads, the gonads are testes, but apart from that, the external genitalia is that of a female. The internal genitalia, there is no uterus, there is no male internal genitalia as well. In this individual, a very characteristic feature is that as androgen is unable to act, there is no development of pubic as well as axillary hair. All these excess androgens are converted into estrogen, due to which there is development of very well developed breast. So 46XY, you are going to get very well developed breast. They will give you it is Tanner stage 5, Tanner stage 4 type of breast. They have very well developed breast. Apart from this, there is no pubic or axillary hair. Pubic axillary hair is absent. As it is 46XY, so there is testis formation as well. But in the testis, there is risk of development of gonadoblastoma. There is risk of cancerous change, that is gonadoblastoma. So how are you going to manage these individuals? You have to perform a gonadectomy, that is removal of gonads. Next question, when are you going to remove that gonads? Gonadectomy is done once the secondary sexual characters have developed, once the person has reached puberty. At that time, you are going to do a gonadectomy. So when will you do gonadectomy? Gonadectomy after puberty, once the secondary sexual characters are reached. So gonadectomy is done after puberty, after development of secondary sexual characters. Another thing that we do along with this, before the patients have sexual intercourse, we can go for a vaginoplasty. These individuals have just lower part of vagina, which is short, small vagina. So for a normal sexual intercourse, we can even do a vaginoplasty for these patients. We can do a vaginoplasty, gonadectomy and vaginoplasty. Just comparing to a condition which is slightly similar in the sense that those individuals are also 46XY. What is that condition where you see that again the gonads are testes, the breast is not very well developed, there is presence of pubic axillary hair, and high risk of development of gonadal tumors such as gonadoblastoma. Swyer syndrome. Your Swyer syndrome. In Swyer syndrome, again, the karyotype is 46XY. Swyer is basically a male with uterus. Here, there is development of female internal genitalia. Uterus is present. Pubic axillary hair development is present. And breast is not very well developed. Breast is poorly developed. Poorly developed. The risk of gonadoblastoma is very high. So in this condition, you are going to do gonadectomy as soon as possible. Gonadectomy is done as soon as possible because of gonadoblastoma. Again, these individuals have uterus, have vagina. There is no requirement for a vaginoplasty as well. Yes, finally coming to the last option, that is Asherman syndrome. So Asherman syndrome again is not a likely diagnosis in a patient who has not attained menarche yet. Asherman syndrome actually leads to secondary dysmenorrhea. Asherman leads to secondary dysmenorrhea. So in Asherman syndrome, the most important risk factor is basically your curettage, such as in your dilatation and curettage that you do mostly in the postpartum period. Maximum risk is in the postpartum period, followed by post-abortal curettage. So Asherman syndrome is not a cause. Asherman syndrome basically presents with secondary amenorrhea. The important risk factor is D and C, and the maximum risk is actually in the postpartum curettage. Postpartum curettage rather than post-abortal curettage. What is the HSG image that you get in Asherman syndrome? Suppose you do an HSG, what will you see? You are going to get a honeycomb appearance or a moth-eaten appearance. You get irregular filling defects. Irregular filling defect, which gives rise to a moth-eaten appearance. Yes, we have so many named appearances. Ground glass appearance, moth-eaten appearance. As we are talking about the various appearances, can you tell me where do you see the string of pearl appearance? String of pearl, yes. Where do you see string of pearl appearance? Very easy question, I would say. Yes. I think as said, there is a slight delay. I'll be getting the answer soon. Yes, yes, exactly. Polycystic ovarian disease. You can see the string of pearl appearance, which is there in polycystic. Very good, very good. Yes, polycystic ovarian disease. Again, where do you see the spoke wheel pattern, cartwheel pattern, spoke wheel appearance, cartwheel appearance? Where do you see that? I'll give you a clue, something related to PCOD. A life-threatening complication of PCOD patients who receive infertility treatment. Spoke wheel appearance. Yes, it is seen in OHSS, ovarian hyperstimulation syndrome. I have provided a question on OHSS as well that we would see soon. Yes, so coming back to our Asherman syndrome, we saw that what happens in HSG, what is the gold standard investigation? That is hysteroscopy. In hysteroscopy, we can see the adhesions and treat it in the same setting. The management of your Asherman syndrome is hysteroscopic adhesiolysis. The gold standard is hysteroscopy, and the management of this condition is hysteroscopy plus adhesiolysis. Yes. So I'm just giving you all the associated points as well. So rather than just sticking to the question, they can slightly modify it next time to get a wholesome view. I'm giving all the key relevant features with the other options as well. Yes, so this is a clear-cut case of your imperforate hymen. If at all they add the option of transverse vaginal septum also, the main point that goes against this is bulge along the entire length of vagina, and imperforate is more common than transverse vaginal septum. And if at all they give that bulging bluish membrane, which was a very favorite question previously, again you will think about your imperforate hymen. Next management is cruciate incision. Yes, let's move ahead to the next question. A 34-year-old mother of 2 children has been suffering from amenorrhea for past 12 months. She has a history of failure of lactation following the second delivery. She remained asymptomatic since thereafter. You see that her FSH level, estrogen levels are low. The skull X-ray shows an empty cellular diagnosis is. Yes, what is the diagnosis? This is typical of your Sheehan syndrome, right? In Sheehan syndrome, what happens? The most important history that you will get is history of postpartum hemorrhage. History of postpartum hemorrhage. Following that, the patient, the first symptom that the patient presents with is the failure to lactate. So, question will sometimes give you history of postpartum hemorrhage. After that, patient has failure to lactate, and after which she has all these amenorrhea and associated symptoms. This is basically due to the pituitary necrosis and pituitary, the hypoxia necrosis that happened following the postpartum hemorrhage and decreased blood supply to your pituitary. Again, the pituitary can undergo necrosis. The X-ray shows an empty cella. There is no pituitary seen. It appears empty on examination. What about the hormonal profile that you get? If there is a problem at the level of hypothalamus or pituitary. So let's divide the problem. Problem at the level of hypothalamus pituitary, problem at the level of ovary, problem at the level of uterus. That means uterus, cervix, or even vagina as well. If you have a problem at the level of hypothalamus and pituitary, you are going to get that the level of FSH is low, the level of estrogen is low. Whenever I write estrogen in reproductive age group, we write E2. What is E2? That is estradiol. Again, a question. What is the most potent form of estrogen? Estradiol. What is the main estrogen seen in reproductive age group? Again, estradiol. So, what we'll be discussing in hypothalamus pituitary causes, you see that FSH is low, estradiol is low. If the problem is at the level of ovary is not functioning, so the level of estrogen is low, but your pituitary hypothalamus trying to make the ovary to work. So you will see that the FSH, which is released by pituitary, anterior pituitary, is raised. FSH is high, estradiol is low. Third thing, if the problem is that the uterus, hypothalamus, pituitary, ovary is functioning well, suppose there is some problem at the level of uterus, such as Asherman syndrome, you will see that FSH is normal and estrogen is also normal. Let's have a look at the options. So again, clearly we have this option of Sheehan syndrome, which is typical of this, but let's have a look at the other options as well. What about menopause? Once the ovaries are failing, let it be premature menopause or even a normal menopause. In those situations, you will see that FSH is high and estradiol is low. Your question has FSH, estrogen, both are low. Coming to the next option, that is your Kallmann syndrome. Kallmann syndrome, again, it is basically due to the defective migration of your GnRH neurons. It is basically a hypothalamic cause of amenorrhea. Typically, they will give you symptoms such as primary amenorrhea associated with anosmia, or even color blindness could be associated. So Kallmann, these are the key features question is going to give you. There will be history of primary amenorrhea, anosmia. Sometimes they give you color blindness. The problem is basically due to defective migration of GnRH neurons to hypothalamus. So this is a cause of hypothalamic cause of amenorrhea. Hypothalamic cause. There is defective migration of your GnRH neurons to hypothalamus. Next, coming to the pituitary tumor. So Sheehan as well as pituitary tumor is also, both are related to pituitary. You can get the similar pictures, but what is the main change? Pituitary tumors, when it is there, you see that the levels of prolactin is higher, due to which the patient actually has galactorrhea. What does our patient have? Our patient have difficulty in lactating. Whereas pituitary tumor, you see that prolactin level is high and the patients present with galactorrhea. Galactorrhea is the one which is associated. So again, if I just change the name of this and I ask you, this cause where hypothalamus and pituitary is affected, that is known as hypogonadotrophic hypogonadism. Hypogonadism. So we write it as hypo. This is hypogonadotrophic hypogonadism. Whereas the next one, where ovary is not functioning well, that is your hypergonadotrophic hypogonadism. Hypergonadotrophic hypogonadism. The third one, where everything is normal, FSH estrogen levels are normal, this is known as normogonadotrophic normogonadism, or I can write as normo. Yes, so they can even change the name like this and ask you as well. It just means the same thing. So correlate with that as well. All right, moving ahead with the next question. You have a 28-year-old patient, para 1 living 1, who has copper T inserted 2 years back. On examination, you see that the copper T thread are not visible. Ultrasound shows copper T is partly in the abdominal cavity. What will you do to remove this? What is the method of removal? So what did you all answer for this question? Yes, You have a patient who has copper T inserted and now the thread is not seen. What is this condition? This is basically a missed copper T. So if you have a missed copper T, what is the next investigation if they ask you? What is the next step or the first step that you're going to do? What is the investigation of choice for this scenario? So if you see that the thread is not seen, thread not seen, or they can even give you thread not felt by the patient. This is basically a missed intrauterine device. The first step is going to be ultrasound, USG, that is we go for TVS. TVS can give you three possibilities. One possibility is that either the copper T is expelled, so it could be an expelled copper T. Next scenario is that the thread is coiled inside, copper T in situ with a coiled thread. Instead of copper T, we can even consider intrauterine device, any intrauterine device with coiled thread. The third scenario is a perforated copper T. Perforated intrauterine device. What are you going to do if you see that it's perforated? Will you just leave there and allow the contraception to work? No, once you see that it is perforated, you have to definitely remove it. It can lead to formation of adhesions, it can migrate, there can be other complications. So once it has perforated, definitely you have to remove it. Initially, you are going to try for removal using laparoscopy. So you're going to go for laparoscopy and removal. If that's not possible, many a times what happens is that even when you do laparoscopy also, there can be dense adhesions which is there that has formed around it. If with laparoscopy you are unable to remove, then only you will proceed with laparotomy. So what's the first step that you're going to do? First, you're going to put in a scope and see whether that property is indeed there or not. Your answer is laparoscopy. If at all you are unable to remove with laparoscopy, there is dense adhesions, you might proceed with laparotomy. So that's the next step after that, after doing laparoscopy. So this here, the correct answer is laparoscopy. What about hysteroscopy? Again, hysteroscopy won't help you because it's just not inside, it has perforated and gone into the uterine cavity. No need to wait, no need to remove, just wait. Again, you can't do that. IUD with hook, again, that is used when your copper T is within the cavity, you can't see the thread. In those scenarios, you can try for IUD with hook, put in a hysteroscope and try to remove all these things. Here, the correct answer is laparoscopy. Laparoscopy, yes. Moving ahead with the next question, you have a patient who has come with incontinence of urine. Dye is filled into the urinary bladder, does not stain the pad in the vagina. Yet the pad is soaked with clear urine. So you have put a methylene blue dye. So you have put, they have not mentioned which dye. Usually the dye that we use is methylene blue dye. And this is known as your 3-swab test, where we insert 3 swabs into the vagina, fill the bladder with methylene blue dye, and then check which swab is getting soaked, stained, and all those things. When you see that all swabs are soaked, but there is no staining, you are basically dealing with a ureterovaginal fistula. So for deeper understanding, let's just go into the 3 types of fistula that you basically detect from this. So for your understanding, let's put 3 swabs into vagina, and let's fill the bladder with methylene blue dye. Yes, I have filled the bladder with methylene blue dye. What happens? Usually this dye does not go into your ureter. As dye is not going into ureter, what is staining the swab is basically the clear urine. That is why you will see that the swabs are soaked but not stained. It is soaked but not stained in case of your ureterovaginal fistula. Whereas suppose you have urethrovaginal fistula, from the urethra to the vagina. Urethrovaginal fistula, you have the dye which comes in, usually it's the lower swab which is soaked and stained. It is the lower swab which is soaked and stained. Ureterovaginal It is usually, typically the upper swab, but of course the gravity is going to act, even it will come to the middle swab and the lower swab as well. Urethro upper swab, which is soaked, but there is no staining. In vesico-vaginal fistula, again, let's have a look at the image. Vesico-vaginal, we typically describe the middle swab, which is soaked and stained. Of course, patient is standing up. Even with gravity, the lower swab can soak. Even if she tilts a bit, upper swab can be soaked. But typically, the one described is middle swab. Middle swab, which is soaked and stained. Yes, you can write plus, minus. It can even go into upper or lower as well. Similarly, this upper one, of course, due to gravity, will come to the middle as well as lower, as described in the question as well. So this is how you are going to differentiate all these three types. Yes, easy question, also known as 3-swab test, also known as your methylene blue dye test. Coming to the next question, this is one question that I often find students get confused. Once the question about prolapse comes, there is so much confusion, right? It's very easy actually. So let's have a look at this question. 14-week pregnant woman with 3rd degree prolapse. What is the best management for this condition? What will you do? So when a patient has prolapse, what I'm not asking about pregnancy, what is the definitive management of prolapse? The definitive management, usually prolapse happen in older females, older individual, usually family is complete. So the definitive treatment that we take is, yes, what is the definitive treatment that I'm not going to ask you about this question as such. Prolapse patient has come to you. What are you going to do? The definitive management, just and not pregnancy, nothing is given. The definitive management is actually vaginal hysterectomy and pelvic floor repair. That is usually for an old individual. Suppose you have a patient who is young and she has come to you. Again, in young, you have to look into the scenario. Is the family complete? Is the family not complete? Is she pregnant? What is the scenario? If suppose the patient is young, family not complete, in that scenario, you go for a sling surgery. We have different types of sling surgeries by which you pull the uterus up and attach it to some structure within the abdominal cavity. So again, you're pulling up the uterus. So family is not completed, young patient, you're going to perform a sling surgery. Suppose family is already completed and many a times they give you something like cervix is elongated. In that condition, you go for a procedure known as Manchester or Fothergill surgery, where you do cervical amputation. You cut a part of the cervix, you attach the rest of it to the sides to your cardinal ligament. You cover it with a vaginal flap, something known as your Manchester surgery or a Fothergill surgery. But this question is none of that. Question is asking you, patient is pregnant and patient has come to you. What are you going to do for the patient? Yes. Again, I can see varied response in the comment section as well. There is answer of sling surgery, answer of so many things. Sling surgery, again, we don't prefer during pregnancy. In pregnancy, what do? We try to do as much less as possible. Again, the surgery itself, there is risk of abortion, right? You are intervening. What will you do? You can just put in a pessary. So question gives you patient is pregnant. Patient has come in the postpartum period. What are you going to do? Just insert a pessary for the patient. Putent elevation is not going to help much. No treatment. Again, not the answer. Sling surgery, I would have gone for if she was not pregnant and family not completed. Yes. So these are the various scenario. Old patient, or they ask you what is the definitive management. It is vaginal hysterectomy and pelvic floor repair, something known as PFR. Vaginal hysterectomy and pelvic floor repair. What do you do in pelvic floor repair? We do anterior colporrhaphy and posterior colpoperineography. This is the surgery that you're going to do for an old patient. Young patient, family not completed, you go for sling surgery. Young patient, family, yes, family complete. It should be family complete. Young patient, family complete. Yes, young patient family is completed. You can go for Fothergill surgery or Manchester surgery. Patient not willing for surgery, in that condition, you will think about pessary, pregnant woman, postpartum woman. Again, you will think about pessary. Patient is unfit for surgery. Again, you can think about pessary. If it is an old patient, unfit for surgery, patient not willing for pessary. In that scenario, we have another surgical option, that is Lee-Ford colpoplisis. Lee-Ford. Again, old patient, unfit for surgery. Pessary is already tried in that. In that, you have an option of Lee-Ford colpoplisis. These are the key points that you should know. Yes. Finally, there is one scenario even where the question gives you patient has come to you with urinary retention in the emergency department. What are you going to do for that? Old patient has come to you with urinary retention associated with prolapse. What will you do? I'll give you options. Immediately shift for a sling surgery, immediately do vaginal hysterectomy, put in a pessary, drain the bladder, and wait and watch. What are you going to do for that? Yes, again, in that scenario too, it is pessary. You will reduce it, you put in a pessary, and you will drain the bladder. Guys, this prolapse itself is not an emergency. Though the patient comes to an ED, you need not directly shift her to the OT and perform a surgery right away. That's not required. This is an elective surgery. Okay, so even in that question where patient presents to you with ED as well, emergency department with all these complaints, main problem is urinary retention. Reduce the prolapse, drain her urine, make her comfortable, optimize the condition, and post her for an elective surgery later on. Yes. Yes, I know so many googly questions now. Yes, but all these things come. Okay, very beautifully. They can frame a clinical scenario on this, and I hope you'll be able to answer all those types of clinical scenarios. Yes, let's move to the next question. A patient treated for infertility with clomiphene citrate presents with sudden onset of abdominal pain, distension, ascites. What is the probable diagnosis in this condition? What are we dealing with? This is typical of your hyperstimulation syndrome, ovarian hyperstimulation syndrome. Just a minute. Ovarian hyperstimulation syndrome, or OHSS. Yes. Thank you, Himanshu. I'm glad that the concepts are clear perfectly. Yes. Okay. So this is your ovarian hyperstimulation syndrome. So what happens in ovarian hyperstimulation syndrome? This is basically, it could be various causes. One is treatment of the patient for infertility, such as when you use gonadotropins, when you use clomiphene citrate. Among these, gonadotropins have more risk. Apart from this, in thin, lean women, younger women who have more number of follicles, in patients who have high levels of AMH, antral follicular count, in those individuals as well, whenever there is stimulation of ovary, there can be excessive stimulation of ovary, leading to this life-threatening condition known as ovarian hyperstimulation syndrome. What happens in this scenario? There is release of a mediator, that is your VEGF. There is release of VEGF or vascular endothelial growth factors into the circulation. So again, in this situation, you see that the capillaries become leaky in that situation. The capillaries are becoming leaky, and you see that there is accumulation of fluid in various parts, such as there could be pleural effusion, pericardial effusion, ascites. So these things can lead to symptoms. So fluid accumulates in the lungs, hearts. What the patient have? The patient can have chest discomfort, dyspnea, breathing difficulty, fluid accumulation in the abdomen. The patient can have ascites and abdominal distension. The patient can have nausea. All these symptoms could be there. Again, the fluid which is within the blood vessels are decreasing, outside is increasing. So intravascular volume is decreasing in the patient. So again, the blood flow to the kidney decreases, the patient can present with oliguria. There can be oliguria, renal failure. Again, thromboembolic complication can happen in this. What is the main mediator implicated? VEGF. They often like to give a clinical scenario on this, where they have abdominal distension, ascites, respiratory discomfort, nausea, vomiting, all these things, and a PCOD picture, PCOD history might be associated. When you look at the ultrasound, you will see this large follicles. So many follicles. Yes, this is your OHSS. Again, this image is very important, guys. This image is very important, I would say. And apart from this, it's important that you should know what is this appearance. It's known as your spoke wheel appearance or the cart wheel appearance. Spoke wheel or cart wheel appearance. So let's write the risk factors as well. The risk factors include this happens in young age women. You can correlate with high number of follicles. High AFC. AFC is antral follicular count. I know dinner time is there. It's not the other AFC. Okay, here our AFC is antral follicular count. High levels of AMH, anti-Mullerian hormone. This happens in thin, lean women. History of PCOD. History of stimulation with usage of gonadotrophins such as your HMG. Even clomiphene citrate can be implicated with this. Yes, these patients can have varied symptoms such as all the symptoms we already described. Again, finally, there can be renal failure or even there can be thromboembolic complications. This is a life-threatening scenario. This is something, it's an emergency that actually the infertility specialists deal with. Yes. So I hope that's clear. Moving ahead with the next question. This is a very pretty straightforward question. Patient has come to you, have put in an episiotomy. They are basically asking you what type of tear is episiotomy. What type of tear is episiotomy? We're going to cut the muscles as well as the vaginal skin and mucosa. Episiotomy is basically a second degree perineal tear. So let's have a look at the various degrees. So the tear, again, remember, you see the deeper it goes, finally you have the anal mucosa. So it is going till the anal mucosa. What all are there? The skin, the vaginal mucosa, next is your perineal muscles, next comes your anal sphincter, finally the anal mucosa. The deeper it goes, the degree of tear extends. First degree, only vaginal mucosa and skin. Second degree means even the perineal muscles are involved. Third degree, apart from this, there is involvement of the anal sphincter. Fourth degree, there is involvement of your anal mucosa or rectal mucosa is stopped. Third degree is again further subdivided as 3A, 3B, and 3C. 3A, 3B, and 3C. 3A as well as 3B involves the external anal sphincter. So what is 3C? Internal anal sphincter. 3A means less than 50% of external anal sphincter is involved. 3B means more than or equal to 50% of external anal sphincter is involved. 3C is internal anal sphincter. So tell me, which is the stage where your vaginal skin as well as perineal muscles are involved? Which is that stage? Where vaginal skin, vaginal mucosa as well as perineal muscles are involved. That is second degree. Exactly, yes. That's exactly second degree perineal tear. Which is the degree where you see that anal mucosa or rectal mucosa is torn? That is your fourth degree. So for understanding, right here, anal mucosa. Which is the degree where external anal sphincter is involved, less than 50%, or I give you 20-30%, that is 3A. Yes, they will give you a clinical scenario. You are an intern who performed a delivery, you saw that tear is extending till here. What are you going to do? Such type of questions can come. Let's have a look into this clinical scenario. 32-year-old patient, 4th gravida, para 3, with 3 previous vaginal deliveries, presents at 38 weeks. She comes with complaints of bleeding. It's not associated with pain. Why do we ask about pain along with bleeding always? What is the condition where antepartum hemorrhage is associated with pain? One scenario, abruptio placentae. Exactly, abruptio placentae. So it is painless. Painless bleeding, we usually think about your placenta previa. Again, pointing towards it, you see that uterus is relaxed. Baby's heartbeat is all right. Hemodynamic ratio is okay. There is no bleeding at that time. Immediate ultrasound was done for localization of placenta. Placenta is covering the internal os on TBS. So again, when it is completely covering the placenta, internal os, that is complete placenta previa. Partially covering is the partial placenta previa as per your older Brownies classification. Newer classification is basically based on how much distance the edge of placenta is from the os. More than 2 centimeter is normal placenta. Within 2 centimeter is taken as low-lying. Covering the os is taken as your placenta previa. What is the next best step in her management? What are you going to do? I want you to answer this scenario. Yes, guys? What are you planning to do in this scenario? Will you induce the patient? Will you do expectant management? Will you do cesarean section? Or will you do artificial rupture of membrane? Yes. So placenta previa, if suppose she's not bleeding, everything was fine in that scenario, we can actually go for a regimen known as McAfee and Johnson's regimen, which is the expectant management, but that maximum is still 37 weeks. Maximum is still 37 weeks. Suppose patient has recurrent episodes of bleeding, we are going to terminate the pregnancy by 34 weeks. Here in this scenario, she's way past 37. She's currently 38 weeks. Now, will you further on go for expectant management? No, you are going to deliver the patient. Now, question is, how will you deliver the patient? Delivery in case of this placenta previa is cesarean section. Delivery is cesarean section. Again, you think the baby can't birth through the placenta. Na? The placenta is way low down. The baby can't pass through the placenta. So you're going to do a definitely cesarean section, or she's going to have massive bleeding when the cervix starts dilating. So the management in placenta previa is basically cesarean section. Yes, there are few exceptions which are there, but as a dictum, if they ask you central placenta previa or mode of delivery in placenta previa, you are going to choose it as cesarean section. Yes, correct answer is cesarean. So McAfee and Johnson's regimen, this is the regimen where you do an expectant management. So as to give an expectant management, patient should be definitely less than 37 weeks. It's maximum done till 37 weeks. Second thing is the patient should be stable. Patient has to be stable. That is no hypotension, tachycardia, excessive bleeding. Next is fetal conditions should be stable. Fetus stable. So what all will you relate with this point of fetus stable? There should not be any IUD. There should not be fetal distress. And finally, patient should not be in active labor. Patient should not be in active labor. Once patient is in labor, you can't go again for an expectant management. Yes, if patient has recurrent episodes of bleeding, when will you terminate? You will not go even till 37 as well. You will go for 34. Patient has a massive episode of bleeding, amount of bleeding is there. What are you going to do? You're going to go for immediate delivery. Patient unstable, massive bleeding, all those conditions, you're going to go for an immediate termination. Only if patient is stable and all these criteria is fulfilled, only then you will proceed with McAfee-Johnson's regimen, which is the expectant management. Again, placenta previa clinical scenarios is a favorite concept that they like to ask as well. So you should know about this thoroughly. Let's have a look into this question. All are done in management of shoulder dystocia except. What is shoulder dystocia? Shoulder dystocia is a condition where your shoulder, baby shoulder, is stuck behind the pubic symphysis. Usually the anterior shoulder is stuck behind the pubic symphysis. So the head has delivered out, the shoulder is still stuck there. What will happen? So it will be something like the head comes out and slightly retracts back, which is known as your turtle sign. So it appears like a turtle, just come out slightly retracted back. So turtle sign is associated with shoulder dystocia. What is the time interval within the delivery of shoulder, the head to the shoulder? You see that head to shoulder delivery time is more than 60 seconds. What are you going to do for the condition? This is an obstetric emergency. In an obstetric emergency, first thing is call for help. You're going to call your whole team. So call for help is the first thing. Mostly call for help is never given in the option. What is the next thing that you're going to do? Next, you will make the patient in Mac-Roberts maneuver. Mac-Roberts maneuver basically आप patient से बोलते हैं पैर को पेट से लगाओ. That's basically Mac-Robert. You're going to flex and abduct the leg. Okay, पैर को पेट से लगाने के लिए बताते हैं. तो इसमें you're going to flex and abduct the leg. This is your Mac-Roberts maneuver. I have provided image as well, which I'll show you in a short way. Next thing that you're going to do is suprapubic pressure. You are going to apply pressure over the suprapubic region. What will it do? Suppose you imagine me as the fetus. If pressure is given from here, the shoulders come closer. The bisacromial diameter actually reduces. So first thing, call for help. Next is McRoberts maneuver. Next comes suprapubic pressure. What will you not do? Students, please note. Which pressure I told? It is suprapubic pressure. It is not fundal pressure. You should not give pressure from the fundus. Fundus is the top part of the uterus above the attachment of your fallopian tube. If you give pressure from there, your shoulder, baby shoulder is going to get again stuck at the level of pubic symphysis. No fundal pressure, no excessive traction from below as well. Okay. Usually, especially if you're a male intern or a male doctor, we feel now you pull with all the strength and the baby's shoulder is delivered out. No, this is not the place where you have to show your strength. Okay, you have to follow this manual. You should not give excessive traction. You should not push from above. You should not give fundal pressure, and you should not ask the patient to push as well. You will call for help. You will do McRoberts maneuver. You are going to give the suprapubic pressure. If all these things does not work out, next you will go for internal maneuvers, that is second line maneuvers. Internal maneuvers, you try to rotate the baby, that is internal rotational maneuvers. You have good corkscrew maneuver, you have Rubin's maneuver. If still it's not working, next thing is delivery of posterior arm. Here again I have given the things as well for your understanding. Call for help, McRoberts, suprapubic pressure. Next thing is internal rotational maneuvers. If still not delivering, delivery of posterior arm. If still the delivery is not happening, you can position the patient in all four positions. All four position is also known as Gaskins maneuver. Gaskins maneuver. Still patient is not delivering. Finally, you are going to go for destructive maneuvers. You have cleidotomy, cut the clavicle. You have symphysiotomy, cut the pubic symphysis. You have Zavanelli maneuver. So Zavanelli, one C is extra. Zavanelli maneuver. In Zavanelli maneuver, again, that's a one-liner that you should know. Once the baby's head has come out, shoulder is strict, everything is done, baby is still not delivering, you will push the head from below back into the pelvis, then proceed with the cesarean section. So you are repositioning the head vaginally into the pelvis, then proceeding with cesarean section. That is your Zavanelli's maneuver. So this is the order in which you are going to choose. Yes, first is call for help, next comes McRoberts, third is suprapubic, fourth one internal rotational, delivery of posterior arm, Gaskins position, finally this. Yes, a very important, very favorite question as well. So let me show you pictures. So what is being done here? This is where you abduct and flex the leg. This is basically a McRoberts maneuver. The second one, where the pressure is given from above, that is your Rubin's, that is your suprapubic pressure. Another name for suprapubic pressure is Rubin's 1 maneuver. That internal rotational maneuver that we saw along with Wood's corkscrew is known as Rubin's 2 maneuver. So another name, very less often name or terminology for your suprapubic pressure is Rubin's 1 maneuver. If they show you an image like this and ask you what is the procedure that is being done, okay, that the page got slightly stuck now. Yes, this position is basically the Gaskins maneuver, all four position. Yes, all four position. Let's have a look at next question. A female 36 weeks gestation presents with hypertension, blurring of vision. Her blood pressure was 180 over 120 and 170 over 110 after 20 minutes. How will you manage this scenario? What is this condition basically? The patient has all the severe symptoms. The BP is more than 160. The diastolic blood pressure is more than 110. She has blurring of vision, headache. These are basically impending signs of eclampsia. There is imminent signs of impending signs of eclampsia, which includes headache, blurring of vision, epigastric pain, nausea, vomiting. So again, question is giving you impending signs, and again, there is severe hypertension with impending signs as well. What are you going to do for such a patient? Any patient with impending signs, it is immediate termination. Any patient with severe hypertension, if she is beyond 34 weeks, you are going to terminate. Here already impending signs are there, so you are going to plan for an immediate termination of the patient. In the meantime, that is the definitive management. But what else what should you give? She is about to throw a seizure. She is about to have a fit. What are you going to give to prevent the seizure from happening? What is that drug that is used to prevent eclampsia? Also in treatment of eclampsia. Excellent. That's magnesium sulfate. So you have to give magnesium sulfate. That's the best drug that you can give here. She has high blood pressure. What should you do? You have to give her antihypertensives. Of course, you are going to antihypertensive. You are going to admit the patient, and definitely you have to terminate her as well. So let's have a look at the option. Admit and observe. I'm not going to just observe. Admit, start antihypertensive, continue patient till term. Of course not. Patient is having blurring of vision, headache, all the impending signs. If you just continue monitoring, she will have a seizure, land up in more complication. Admit the patient, start antihypertensive. Excellent. Admit all antihypertensive, follow up the patient. Again, no. Yes, I hope all the concepts that you require with this is clear. Patient has just severe hypertension, you terminate by 34 weeks. Nothing is there. Generally, just hypertension, you terminate by 37 weeks. If the patient has any impending signs of eclampsia, if there is problems with the baby, such as fetal distress, if there is abruptio placentae, if there is HELP syndrome, in all these scenarios, you are going to go for an immediate termination. The best drug that you can give at this point of time is magnesium sulfate to prevent the seizures, and also next is antihypertensive. If at all you have to choose between those, most important one now is magnesium sulfate. Moving ahead with the next question, 30-year-old woman develops deep vein thrombosis in her left calf on the 4th post-operative day. The patient is started on heparin and scheduled to begin a 6-week course of warfarin therapy. Patient is devoted mother who wants to breastfeed her baby. So breastfeeding woman warfarin, what do you think? So let's just go through the course of warfarin, heparin, and all those things. So warfarin in high doses actually causes warfarin embryopathy in the fetus. So what do we do in pregnancy in the first trimester? So if patient was on warfarin and now she becomes pregnant, we usually shift the patient to low molecular weight heparin. The drug that we usually give is enoxaparin. Yes, enoxaparin. Following that, you are going to again shift her back. After 12 weeks, actually, warfarin is a much better anticoagulant as compared to heparin. After 12 weeks, you will shift her back to warfarin. By the time she's about to deliver, that is by 36 weeks itself, you have to shift her again back to low molecular weight heparin. What about after delivery? After delivery, understand that we do a small switchover where we use heparin as well as warfarin. And finally, we convert only to warfarin in the postpartum period. And this warfarin is absolutely safe for the baby. It's not transmitted through the breast milk. I'm telling after delivery, not during pregnancy. After delivery, there is no problem for the baby because it's not passing through the breast milk. There is no contraindication for lactation when you give warfarin. You can safely breastfeed the baby when the patient is on warfarin. There is no contraindication. So you can tell this devoted mother who wants to breastfeed, just go ahead. You can continue with the feeding. Okay. कोई भी प्रॉब्लम नहीं होगा, आपके बच्चे में बिल्कुल फीड कर सकते हो, ठीक है? So, which is not included, next question, which is not included in the active management of 3rd stage of labor. So again, active management is a very favorite question, I would say. Why do we do active management of 3rd stage of labor? To prevent excessive bleeding. What is the first thing that you're going to do? As soon as the baby delivers, within 1 minute, you have to give uterotonic. And usually we give oxytocin 10 international unit within 1 minute of delivery. What do you give? You give oxytocin. What else do you do? We usually proceed with a delayed cord clamping. We wait for 1 to 3 minutes. Delayed cord clamping. Delayed cord clamping has so many benefits. Delayed cord clamping actually has so many benefits, I would say. In delayed cord clamping, the risk of anemia decreases. You are giving the time, the extra blood volume is going to the baby. You are giving time for the fetal circulation to get established. So we prefer a delayed cord clamping. How much time can we wait? 1 to 3 minutes. All these are questions, guys. So immediate cord clamping is never a part of it. Then you go for delayed cord clamping and a controlled contraction and the delivery of the placenta. Even controlled contraction and delivery of placenta is also done, which is done by a method known as Brandt-Andrews technique, this method of controlled contraction and delivery. Finally, last thing is you are going to assess for the tone of the uterus. You check the tone is less, then you start massaging the uterus. So previously, uterine massage was taken as a routine step, but currently WHO is telling if you feel that tone is decreased, then only you need to start massaging. Why? You require a dedicated professional to do the massage. And second thing, you are wasting that person's time. Second thing, uterine massage itself can cause some discomfort to the mother as well. So uterine massage was a part routinely previously. Now they are telling go for uterine massage if the tone of the uterus is decreased. What will you routinely do? You will assess for the tone of uterus. So now you have two options. Among this, immediate cord clamping was never a part. Massage of uterus is done if the tone is decreased, not a routinely done, but still it is done if tone is decreased, which is never ever a part of active management. It is immediate cord clamping. Tell me a few conditions where you're going to do immediate cord clamping. Yes, where the baby is asphyxiated. If the baby has asphyxia, you require resuscitation. So you have to immediately clamp the cord. Just hand over to the pediatrician. Let them do whatever they have to do with the resuscitation. Don't keep the baby with you for long. Yes, you will immediately clamp and pass the baby to the pediatrician. Yes. So next thing is, apart from this, if you have an RH negative mother, non-sensitized RH negative mother, or if the baby has heart disease, you don't want the extra volume to go into the baby, or an RH negative, you don't want the increased fetal-maternal hemorrhage and the mixing of blood to happen. All these scenarios, you're going to go for an immediate cord clamping. As per our National AIDS Control Program and NECP guidelines, we go for a delayed cord clamping only for the HIV positive mothers. Yes, among many international guidelines, they go for immediate cord clamping, but what we practice is again delayed cord clamping even for HIV positive babies. So we have discussed a lot of points related to active management of third stage of labor here. Yes, again, that's a crucial and important topic. Let's have a look at this question. Indication of cesarean section in case of intrauterine death includes which of the following scenarios? In a patient who had an IUD, which of the following scenarios will you go for an cesarean section? Can you answer in the comment section? Yes, Anjul, excellent. Anjul also mentioned HIV according to this. Very good. What are you going to do? Anuj, not Anjul, Anuj, yes. In which among the following are you going to go for a cesarean section? Yes. I can see D, I can see B. Which one is it? Is it B or D? Yes. Let's start with our abruption. In abruptio placentae, if the baby is dead, again, that's a clinical scenario. They give you, there is a patient who have antepartum hemorrhage with tender uterus, there is pain, there is history of trauma, all these are going to be there. If you have an abruption patient, and the fetus is dead, now there is no requirement of cesarean section. You are going to initially try with an ARM and oxytocin. Usually the delivery expedites with this ARM and oxytocin. If that's not happening, only you will consider cesarean. The patient gives you IUD with abruption. Next thing you are going to try for is ARM and oxytocin attempt for vaginal delivery. Even in previous one cesarean section, you have your option of TOLAC, trial of labor after cesarean section, TOLAC VBAC. Already this mother has gone through the trauma of a baby's death, fetal death. You don't have to put in an unnecessary trauma of a second and F a cesarean section on top of it to her as well. There is no requirement to go for a cesarean section in previous 1 CS or placental abruption that is associated with IUD, which is the absolute indication here, central placenta previa. So for those who answered D, I hope that's clear. Yes, in both the other scenarios, you can attempt for a vaginal delivery. And in abruption, what are you going to do if they ask? It is ARM followed by oxytocin. Artificial rupture of membrane followed by oxytocin is what you're going to do. Yes, a woman presents with eclampsia is started on magnesium sulfate. What is the first sign of toxicity? This is an age-old question, I would say. Yes, very favorite question. So magnesium sulfate, as you know, it's a wonderful drug, helps to prevent eclampsia, treat eclampsia, used in severe hypertension. But the problem is that it has a very narrow therapeutic range. The narrow therapeutic range is between 4 to 7 milliequivalents per liter. You have to maintain it between 4 to 7 milliequivalents per liter. What will happen? Beyond this, there is signs of toxicity that is developing. So these patients require very frequent monitoring. So usually whenever a patient is started on magnesium sulfate in the ward, in the ICU, not in ward, in the ICU, you will always see an intern who is searching for your knee hammer. Yes, because the first thing or the most important thing that you're going to monitor is the knee jerk. The first sign of toxicity is loss of knee jerk, also known as the deep tendon reflexes, absent deep tendon reflex, loss of knee jerk, loss of patellar reflex. This is the first thing that you're going to see in this condition. Next comes respiratory depression. Finally, there is even cardiac arrest. The first sign of toxicity is loss of knee jerk, absent deep tendon reflex, yes, absent patellar reflex, all those things, same thing. Yes. Next comes the respiratory depression. Finally, the patient goes into cardiac arrest. Usually, there is not reduced muscle tone. Again, that's not the thing. You see that loss of knee jerk is the typical thing that you see along with your magnesium sulfate toxicity. When you see that there is loss of knee jerk, or if you see that there is respiratory rate has gone less than 14 per minute, or if you see that the urine output has decreased. How much is decreased? Urine output is less than 30 ml in the past 1 hour or less than 100 ml in the last 4 hours. Immediately stop your magnesium sulfate. Again, I'm repeating. If you see that the knee jerk is absent, respiratory rate is less than 14, third, you see that urine output has less than 30 ml in 1 hour or 100 ml in 4 hours, 31 hour, 104 hours. In that situation, immediately stop magnesium sulfate and you are going to give the antidote. What is the antidote that you're going to give in this scenario? Antidote that you're going to provide is calcium gluconate. You're going to provide calcium gluconate. Yes. Excellent. Sean and Anuj has rightly commented 30 ml in 1 hour, less than 100 ml in 4 hours, which is excellent. That even came recently for the NEET exams as well. Yes, so might be thinking about that as well. Yes. Okay, so moving ahead. Identify the uterine anomaly shown in the HSG image. What is this uterine anomaly that you see here? So whenever you get an HSG, don't jump to a diagnosis. Always be patient. Start tracing from below. This is a very clear-cut scenario. You can see a cannula here, which is used. What is that cannula which has this spiral groove like this and which is inserted to put in the dye? That is basically your Leach-Wilkinson cannula. Yes, Leach-Wilkinson. This is Leach-Wilkinson cannula. Leach-Wilkinson cannula. Yes, let's move ahead. So what are you seeing here? Here you can see that one-sided uterine cavity and a bit about the fallopian tube as well as only one-sided uterine cavity, one-sided fallopian tube. This is basically a case of uniconvate uterus. Uniconvate uterus. Let's see what about the others. Septate, your didelphys, biconvate uterus. So this uniconvate uterus, what you see here, this is known as a banana sign. Yes, it looks like a banana if you are very creative. Yes, banana sign. What do you typically see? Only one-sided uterine cavity, one fallopian tube. That is your uniconvate uterus. Uniconvate uterus. Let's have a look at this scenario and students, please tell me, what do you see here? Again, let's start tracing. You see two cervix, two uterine cavity, two fallopian tube. Very favorite question. Even they can give this as a clinical scenario. They will tell you that two uterine cavities, two cervixes. Or they can give you as an image and ask you, please tell me what is the diagnosis. Very easy diagnosis. What is it? Yes. This is Uterine didelphys. This is uterine didelphys. Didelphys uterus. Yes. Uterine didelphys. Very good. Next, coming to septate and bicornuate uterus. This is where the students have doubt. Both septate as well as bicornuate, if you see, it appears something like this. Because in bicornuate, this is basically due to the two uterine cavities attaching to fallopian tube, whereas in septate, this is basically due to the septa, which is there in between, and the dye is basically filling this region. Here also, let me fill the dye. So the key features that help you is if you take this angle as well as the distance. This angle, let's first look at one. This angle is acute. So the angle that you see is acute in case of a septate uterus. So septa, you remember, is closer by, it is acute, whereas obtuse angle is seen in case of your bicornuate uterus. It's further apart, you see an obtuse angle. The distance, the intercornual distance that you see, this distance is less than 4 centimeters septate, whereas bicornuate is at a more distance. So closer by, if you see, that is septate. In simple words, farther away, if you see, that's your bicornuate. What are the specific details? The angle is acute, less than 4 centimeter intercornual distance, septate, more than 4 centimeter obtuse angle, that is your bicornuate uterus. Yes? Yes, you are going to see from there. We have to show fundus for this. Fundus, yes, we have to show it, but that comes in your gold standard examination. Now, you are unable to see that, but once you do the laparoscopy and hysteroscopy, which is a gold standard investigation, you can, of course, see the fundus, how it is, and come to that diagnosis as well. Yes, this is how we are going to differentiate these components. Next, coming to question on aneuploidy screening, all are components of your quadruple marker except. So what are the components of quadruple marker? You can remember it as A, B, C, I. What is A? A stands for alpha fetoprotein. B is beta HCG. C is not that simple. C is actually unconjugated. Estriol, E3. And I stands for inhibin. Which inhibin is it? It is inhibin A. It's actually inhibin A. Yes, excellent. So tell me one condition or one ovarian tumor where you get inhibin B as a tumor marker. In quadruple marker, I taught you inhibin A, which is that ovarian tumor which has inhibin B as the tumor marker. Yes, that's your granulosa cell tumors, because granulosa cells are going to produce estrogen as well as inhibin B. So the tumor marker that is associated with granulosa cell tumor is inhibin B. This here, what you're seeing is inhibin A. Can you tell one structure that produces inhibin A in normal reproductive cycles, every menstrual cycle? One structure produces inhibin A. What is that? Yes, corpus luteum. So students often associate corpus luteum with progesterone, right? Corpus luteum, you all know, produces progesterone. Apart from that, corpus luteum also produces estrogen. Apart from that, corpus luteum also produces inhibin A. Inhibin A. Yes. So let's come back to the question all about inhibin A and B. Yes. So coming back to the question. So these are the 4 markers that you do in quadruple marker. When do you do quadruple marker? It is done in the second trimester. What happens if you have a patient with Down syndrome? You see that AFP decreases, beta HCG increases, unconjugated estriol decreases, inhibin increases. You can remember that beta HCG is big and inhibin is increased. Either you can remember like that, or you can remember that signs are alternating. Decrease, increase, decrease, increase is how it goes. This is what happens in Down syndrome. Coming to the next question, you have a 30-year-old primigravida. So this is more of an applied type of question. She has come to you with labor pain, second stage of labor. She's exhausted. Okay, exhausted. And you see that patient has started bleeding. She has tachycardia and hypotension. Placenta did not deliver. And afterwards, you see that there is shortening of umbilical cord. There is shortening of umbilical cord. Obstetrician attempted manual removal but could not reach the placental attachment itself. What could be the best step in management of this condition? What is it? What is the best step in the management of this condition? What are you basically dealing with? What are you dealing with? Are you dealing with a retained placenta such as adherent placenta, or are you dealing with something else? This is basically a uterine rupture scenario. So what do you see normally in the third stage? You are going to see that along with the placental separation, one sign is as placenta separates, there is lengthening of cord. Suppose the uterus ruptures and placenta moves into the abdominal cavity. The cord actually shortens. This shortening of umbilical cord, you can't even feel the edges of your placenta. All these are pointing towards a uterine rupture. So what happens in uterine rupture? There can be tachycardia, there can be hypotension, you lose the baby, there can be intrauterine death as well if it happens early. If suppose baby was inside itself, what can happen? You will feel the station of head, and suddenly as the rupture happens, baby moves into the abdominal cavity, you feel that the station is not felt. So loss of station of head. Another feature that they can give is baby's fetal parts are easily felt. You can feel the fetal parts very easily. This is a scenario after delivery. This is happening. If suppose with baby that these things are happening, there is sudden cessation of contraction. There is loss of station of head. The fetal parts are very easily palpable. All these are the features that can be given. Along with it, here the point is a hypotension, shortening of umbilical cord, and all this. What do you have to do? Immediately go for a laparotomy. Immediately go for a laparotomy. If repair is possible, you go for a repair. If repair is not possible, to save the life of the woman, you will immediately proceed with even hysterectomy. So repair is not possible or difficult, directly you will go ahead with hysterectomy. This is basically a scenario of your uterine rupture. Uterine rupture, where all the layers of the uterus is disrupted, that is uterine rupture. Before uterine rupture happens, there is a stage of uterine dehiscence, where all layers are not fully disrupted. Some layers are still intact, such as the serosa of uterus. In that scenario, you have to detect at this stage, what all will you see? You will see that in the mother, tachycardia appears first. Then in the baby, there can be fetal distress. When you put your hand over the previous scar, there can be scar tenderness that you experience. If there is dehiscence, rupture does not happen, immediately go for a cesarean section to save the baby. To save the baby, you will go for an immediate cesarean section. Finally, the last question on Anemia Mukt Bharat program. What is the management of mild to moderate anemia? So for this, first tell me what is anemia in pregnancy. Anemia in pregnancy is again divided as physiological anemia, pathological anemia. So what is physiological anemia? Hemoglobin level, which is between 11 to 11.9. So again, let me draw a timeline. So 11, 10, just let me add 12 as well. Yes, to add in physiological. I always teach this with a timeline to make it easy for the students. Just remember like a timeline. Yes. So 11 to 11.9 is something that happens normally in pregnancy, which is known as your physiological anemia. Why does physiological anemia happen? This is basically due to hemodilution. Physiological anemia. This is due to hemodilution. Yes. 10 to 10.9. So anything less than this is pathological anemia. 10 to 10.9 is taken as mild anemia. 10 to 10.9. 7 to 9.9 is taken as moderate anemia. Less than 7 is taken as severe anemia. If suppose a patient has mild to moderate anemia, as per Anemia Mukt Bharat program, mild to moderate anemia, you again divide it as less than 34 weeks, patient more than or equal to 34 weeks. If patient is less than 34 weeks, mild to moderate anemia, you are going to treat with oral iron. How much oral iron do you give? We usually give 1 red pill for prevention, 2 red pills for treatment. That is double the dose. So you are going to give 2 red pills as it is for treatment. 1 red pill contains 60 milligram of elemental iron. That into 2 means total how much will I give? 120 milligrams of iron, and folic acid is 500 microgram into 2. 500 microgram into 2, that is 1000 microgram. If suppose patient is already beyond 34 weeks, you directly proceed with parenteral iron. We directly proceed with parenteral iron. That is IV iron. Parenteral iron, the commonly given preparations include, you have ferric carboxy maltose, which is the best one, but it is expensive actually. The commonly used one is iron sucrose. Iron sucrose. Both these are usually given as IV regimen. Yes. If suppose patient is not compliant, patient is not compliant to your treatment with oral iron, if you see that there is inadequate response, there is inadequate response. What is the most common cause of inadequate response? It is usually due to non-compliance. It is very difficult to take this iron tablets. Okay, there is gastritis, nausea, patient is not taking is the most common cause. Why her hemoglobin is not rising? Yes. So in that scenario, again shift to IV iron. With this knowledge, let's have a look at this scenario. Iron and folic acid, 3 tablets. You are overdoing it. Don't overdo it. You just require 2 tablets. Give oral iron as well as IV sucrose. No, again, you're overdoing it. You are not going to give both as well. LCM, ferric carboxy maltose, it's not given as IM, it's given as IV. Again, wrong. IV sucrose for non-compliance with oral iron? Yes, sounds right. So you are going to give IV sucrose for non-compliance with oral iron, which is the correct regimen that you're going to use here. Yes, this is how I can see the correct answers. Yes. Can IV iron be given in the first trimester? Oral iron can be even given in the first trimester if the purpose is for treatment. But IV iron is actually fetotoxic. You will not give IV iron. You will not give IV iron in the first trimester, dear Bishnoy. That's your answer. We are not going to give IV iron. Yes. So that's what you're going to do. Yes, AIM-7 has written hemodilution causes anemia. Excellent. Dear. Physiological anemia is due to this thing, AIM-7. So I hope I see you soon in AIMS as well. Yes, you have actually started the manifestation, I think. Now, yes, positive manifestation, positive thinking. The name itself is positive. Yes. So study well, give your maximum for the NEET exams, do the questions, practice questions, revise thoroughly. Again, after the counseling, there's after the NEET exam results, there is no news about the counseling. So don't wait for that. Give your maximum for the NEET exams, and you never know when you play. You have already studied so much for NEET and everything. So keep on revising the high things, keep on revising the things that you forget, and wish to see all of you in AIMS soon, and best of luck for the exam. Yes. Never think that you are inadequate, you can't get into AIMS. There is nothing like that. The main thing that's holding back you is yourself, I would say. Yes, it's coming from someone who felt the same way. Many years back, even I felt that AIMS is too unachievable, it's too difficult. The moment you start believing and you get trying for it, you have taken the first right step, what you need for it. And that's the most important step. Believe in yourself. Don't have that self-doubt. Just keep on working on yourself. Don't think about that end result. Don't think that's going to be something too high to achieve. Nothing like that. Keep on working on yourself. Keep on improving yourself. Keep on revising. Utilize each and every minute now. It's very important. Yes, with a very targeted approach, you are going to definitely clear this. Yes, and wish to hear from you all as well once you clear this. You can connect to me as well anytime. I'm available on Insta. My ID is OBG with Gayathri. And many INICET short videos I had done in my channel as well in YouTube. You can go through that as well. Yes. OBG underscore with underscore Gayathri. So any doubts, queries, you can connect to me on this. And if at all, after this also, after the exam, please feel free to connect. Let's discuss and wish to hear from you all after the exams. Yes. Thank you so much, AIM7. Thank you, Anuj. Thank you, Sean Parker. Yes. Okay, then. Study well. Yes, I know exams are very close by, so I'm not consuming much time. That's why I kept the session to a small session. So any doubts, questions, queries, feel free to connect to me. Thank you, guys.
Recording stopped.